Usually like to wait till we're in about 2 minutes. It's about 2 minutes after noon, so we're going to begin our program. Just to remind everybody, this is Cardiology Grand Rounds. Welcome to Grand Rounds. This is a CME or continuing medical education program. With your invitation, you received a review sheet, after the program. So you should try to fill that out. That sheet is necessary for CME. So please fill that out and get it back to Tina Morfeld. It's my pleasure today to introduce our speaker, who's one of our newer attendings and rising super. So is
He's rising.
Dr. Weinstock, we lost you.
How about now?
It's better.
Okay, I'll get closer to the microphone. Anyway, I want to introduce Mario Caruso, who is a graduate actually of Rutgers University in New Brunswick with a Bachelor of Arts in Exercise Physiology, cum laude, and then went to Rowan School of Osteopathic Medicine for his doctorate, and then went to Lankenau Medical Center for internal medicine training, and then finally Lehigh Valley Health Network in Allentown, Pennsylvania, where he's completed his fellowship in cardiovascular disease and in sports cardiology. We'll talk about that. He is board certified, of course, in internal medicine, but also cardiovascular disease, nuclear cardiology, and echocardiography. He is very interested in sports cardiology, and that's the topic we're going to talk about today. And in particular, in the COVID world, he's published on this. He did special training and work with the Lehigh Valley Heart Institute, sports cardiology program in Allentown. He also works with Rowan University in their exercise physiology department. Got a number of peer-reviewed publications and many abstracts and presentations. And we're really delighted for Dr. Caruso to join us today. So Mario, take it away.
Thanks, Dr. Weinstock. So for those who don't know me, I'm Mario Caruso, one of the new cardiologists, and I'm going to be talking about sports cards and particularly some COVID stuff towards the end of the talk, since it's very relevant at this point in time. So we'll get started with some fun background, and over here first go over this is what we're going to go over today. I have no disclosures, just a quick overview of sports cardiology, some epidemiology. Then we'll talk about the characteristics of exercise and why that's important in relation to athletes and in general anyone who's exercising. We'll talk about the cardiac response and remodeling that you see with particular types of exercise. Then we'll talk briefly about the culprits of sudden cardiac death, which honestly could be a whole lecture in and of itself, so I'll just touch on a couple of them. And then we'll get into the COVID data and COVID myopericarditis, and then briefly at the end just talk about the response to sudden cardiac death in the sports world and how that's being approached at this point in time. So just some fun background here. So apparently, way back when in 490 BC, Phidippides, if I pronounce that correctly, ran all the way back from Marathon after the Greeks won a battle against the Persians, and shortly thereafter had an arrest. And apparently the first documented exercise-related death, they actually talk about this in the ACC guidelines, I think just for some fun educational background. And then listed below, there's some Greek physicians that were thought to be fathers of sports medicine, and a Greek physician actually for the gladiators, which is kind of interesting. So what is our role as a physician in terms of what we're supposed to do when talking to athletes, and where is this field going? So it's quite a new field, honestly. And the reason is the management of an athlete is pretty complex. You know, it requires a multidisciplinary team. Oftentimes you're talking to trainers, you're talking to team nurses, you're talking to team psychologists about how to approach an athlete and where to go in terms of risk stratification and return to athletic competition. Now, throughout this talk, I'll talk a lot about athletes, but also about amateurs as well. So, really anyone who wants to participate in moderate, high-intensity exercise or really just start an exercise program, it's really worth, in your brain, thinking about what's appropriate for them and overall risk stratification for them. And going along with this being a bit of a new field. So in 2011, the ACC developed an exercise and sports cardiology section. And then more recently, there's ACC guidelines in 2015, and they're actually planning on publishing new guidelines in the next year or two as well, a bit of an update. And then the European Society just published guidelines in 2020, which are fantastic in my opinion. And then the ACC just put out new guidelines for HCM as well. So a lot of new stuff out there, a lot of new data, a very fluid and evolving field, which is great. And overall, what we're looking to do and what these guidelines do and what my theme of the talk is, we're really just trying to protect athletes and minimize adverse events, whether it be sudden cardiac death or even just events during sport. So what's very important, and obviously we all know this, history, physical exam, and as needed testing. And the reason is what we're trying to figure out is, can these individuals go and play sports or go and exercise without any further workup? Do they need further workup, or do they have immediate disqualification? And we'll get into what fosters each category. Now, also a lot of times, we have cardiac rehab, but that's something that a lot of patients after events, after whether they be young or old, want to know what's the right way to go about returning to exercise. And that's something in terms of a cardiac rehab perspective, but even just a return to exercise that we'll touch on very briefly. And again, the theme, prevent sudden cardiac death. So you want to risk stratify, you want to minimize adverse events, and promote safe exercise participation. So in doing so, we're looking for things that would put someone at an unreasonable risk of injury or death. Now, this is a debatable thing, and the European Society of Cardiology has very different views from the ACC in terms of screening athletes and what's appropriate and what's not appropriate. So the ACC says there's general, although not universal, agreement with the principle that screening to detect important disease and potentially prevent sudden death is justified and potentially beneficial. So a lot of hedging there. Now, what's definitely recommended by both societies, really need to take a very detailed history. And history, the things you're looking for, obviously syncope, chest pain, shortness of breath, but shortness of breath in particular, if somebody says they were able to run 5-6 miles easily and all of a sudden they're limited to 3 miles, for somebody who's in cardiology fellowship, 3 miles might be a good achievement, but for somebody who's an avid long distance runner and now all of a sudden they're short of breath after 3 miles, that's actually pretty concerning, especially if their exercise frequency and duration has not really tapered off. Now, family history, the things I always ask people, obviously, family history of early cardiac death, and then you can elaborate from there, whether it's sudden or somewhat expected, but you really want to know if there's any premature or sudden deaths. And then obviously cardiomyopathy histories, connective tissue histories, that kind of stuff you really want to get into to get a detailed family history, because a lot of these conditions that predispose individuals are hereditary to some degree. Now, if you do a history, you do a physical, and in this world we do ECGs, even though again the cost efficacy of that is debatable. We say usually if there's no warning signs, people can go play sports. Now, again, the ACC and American Heart Association actually recommend against routine ECGs, but the European Society, which in a lot of opinions of experts is a bit more advanced than ours for the sports recommendations, does recommend routine ECGs. Mostly because they're not cost prohibitive, they're quick, easy. But the reason is we're not really sure what to do with them. So, an ECG is something that doesn't have a definitive impact in the young individuals because we're not sure what certain findings mean. So there's several published criteria for ECGs and where to go and how to know what to do next. This is the most recent, which hasn't been updated in a little bit, but some things I wanted to point out, which may be abnormal for some, but not for a young, active individual. Some things we get a lot of referrals for, so junctional rhythm in particular. So junctional rhythm, I've gotten several referrals for already, really just due to high vagal tone. Somebody has a resting junctional rhythm. The way you know that it's not abnormal, have them walk around the room, have them do any type of physical activity, and their sinus node should take over and they'll be in sinus brady or normal sinus rhythm. Otherwise, you can have significant ST segment changes. So here, ST elevations followed by T wave inversions in V1 through V4, particularly in black athletes. You see that a lot. Scary ECG, but probably normal in that particular patient population. And then the abnormal ones, you definitely know are abnormal. Something I want to point out though, in the abnormal section, so PR interval, a lot of times, again, going with vagal tone, which is a lot of reasons for these ECGs, you'll see athletes with PR intervals, 300, 350. Honestly, it's normal. And again, if you exercise them, it tightens up a bit. And that's because the vagal tone decreases at that point in time. But when you start getting closer to the 400 range, that's when you start to worry a bit. So now, again, sudden cardiac death. So that's a pretty vague term. We don't really know what's encountered in that. And that's where a lot of debate comes about what is a sudden cardiac death. So you can see the definition by the ACC here. Again, it's a bit vague. So a non-traumatic and unexpected death that may occur from cardiac arrest within 6 hours of a previously normal state of health. So that's pretty broad, pretty vague, and who you're putting in that, who you're not counting for that, that's where a lot of debate comes in about incidence and frequency and what we really should be doing about it. But what we do know, of course, it's emotionally devastating. I don't know if anybody's ever seen a young athlete have an arrest, but it's pretty scary. Most recently in the Euros for soccer, which I'll mention at the end, there was one, worldwide television, somebody had a sudden cardiac arrest, pretty scary. And as we know, most commonly triggered by VT or VF, there's usually an underlying substrate, of course, which leads to that malignant arrhythmia and causes the person to have an arrest. So again, kind of leading into this, widely debated. Anyone have a general idea of what the incidence is for individuals less than 35? You can throw out random guesses, A, B, C, D. C?
Yeah.
C. All right, beautiful. So again, widely debated. So you'll see a lot of papers, and specifically the European Society talks about specific references will say as high as 1 in 50 or maybe as low as 1 in 300. And that's really due to a lot of different factors, which I'll talk about on the next slide. So, what does it affect? The numerator is the big thing, right? So what we're talking about in that regard is, are we only counting deaths during sports or activities, or any death, any time for an athlete that's sudden? What about somebody who's resuscitated? Is that counted as a sudden cardiac arrest? Are we counting them? And what should we do with those patients? What about, are we counting all deaths in athletes, even that are non-cardiac, if they're sudden? That's something, something that has to be considered as well. And what about reporting? Obviously, it's really hard to report this. There's one pretty well-known national registry, but if you don't know about it, you're not going to report it to that registry, and it may not be reported correctly. So again, this is where the numbers vary so drastically depending on what research article or what paper you read. And then at this point in time, there's still no mandatory reporting. So that's another thing that changes what's, on top. And then in terms of the denominator, who's considered an athlete? Somebody, that exercises on a somewhat frequent basis considered an athlete? Or are we counting collegiate athletes? We're counting high school athletes? Who's considered an athlete? And that's where we get the true incidence being widely debated. And that's why I said anywhere from 1 in 5,000 to 1 in 300,000, which is a huge difference, obviously. But in general, most societies will say among 100 to 150 competitive deaths during sport in the US annually. So pretty frequent, so on average every 3 days or so. If you look at it that way, it's pretty prevalent. Of course, again, who you're counting as an athlete and what you're counting as a sudden cardiac death is debatable and variable. So this is the registry I was talking about. So there's a US registry for sudden deaths in athletes, started in 1980 or so by the Minneapolis Heart Institute, which a lot of the athletic data comes from. And they assembled this data. They put out some information in 2016. I actually just looked before this. They haven't re-put out more information, but they're still collecting data. And the mean age for sudden cardiac arrest in these athletic population was around 19, 74% during competition. And you can see based on these numbers, there's probably some reporting bias, honestly. And that's why, this is very debatable. Oops, sorry about that. And they report that African Americans are, almost more than 3 times higher incidence of sudden cardiac arrest. So what about collegiate association? So the NCAA started doing this as well. And what they found was 2.3 per 100,000 participants experienced sudden cardiac arrest. And the NCAA is an evolving field in terms of what they do for screening, what they do for recommendations based on findings, and how they go about it. But as you can see, the higher level athlete tends to have more events, which makes sense, and I will get into why that is the case. And Division I male basketball players have the highest incidence, which again, I'll get into about the physiology behind that in a little bit. The gentleman pictured on the right is Hank Gathers. He was probably one of the more famous, unfortunately famous, sudden cardiac arrests back in the late 80s. He played basketball for Loyola Marymount, and the game was on national television, and he had a sudden cardiac arrest at half court, got up, nobody really knew what happened. He played another 5-10 seconds and then had an arrest again, and unfortunately passed away. And on autopsy, found to have hypertrophic cardiomyopathy. So that's why these events are so socially devastating, you know, especially young, healthy, otherwise healthy individuals. So here's the data from the Minneapolis Heart Institute. So again, we'll talk about why certain sports have a higher prevalence, but basketball, football, soccer, so, you know, not morning yoga or riflery or anything like that. So when we talk about why certain sports have a higher incidence of sudden cardiac death, first we have to understand what goes into the particular type of exercise that those individuals are participating in. So when we talk about type, is it endurance? Is it speed? Is it flexibility? Is it a combination of all those? And then the mode of exercise makes a big difference into risk stratification and their risk for events. So are we talking mostly aerobic? Are we talking anaerobic? Are we doing dynamic exercises, continuous interval training, large muscle groups, small muscle groups? All those things play a role in the physiology behind it, and then what evidently increases risk for individuals. And then of course, you know, frequency, intensity, time, duration, all that stuff plays a role. So, you know, this is important for the athletic population, but it's also important for somebody who's 35, 40 years old, comes in, wants to start an exercise program, needs some advice in terms of risk stratification, what to do. And you have to know, you know, what am I recommending, frequency, intensity, time, that kind of stuff moving forward. So when we talk about that, so this is from the European guidelines, nice little chart. Obviously, you're not going to tell your patient, get to 70% your VO2 max for high intensity exercise, but we can tell some of them heart rate. You know, a lot of them now have heart rate monitors, whether it's an Apple Watch or what have you. And, you know, we all know the recommendation, 150 minutes a week of moderate intensity exercise. And that's generally 55 to 74% your max heart rate. But something that's really good that I often tell patients is rating of perceived exertion as well. So that's over here. So on a scale of 20, how hard do you think you're working out? And when you're going through it, something that's also very important in terms of reaching high intensity exercise is getting to your lactate threshold. So your lactate threshold essentially, you know, is when you're accumulating more lactate in your body than you can clear. Everybody has a baseline level of lactate, it's there all the time. But when you start switching from aerobic to anaerobic and producing more lactate that you can clear, that's your lactate threshold. And what you can tell patients is the talk test. So if you're recommending somebody moderate intensity exercise, no more, if they're able to do the exercise and complete a sentence or two, generally they're not at their lactate threshold and they're in the right range. Once they start, you know, when you're working out hard, you start chopping up sentences and have to take a big breath in between, or if you're walking upstairs in the hospital with an N95 on, you're producing more lactate that you can clear. So that's that. Now, with those the background of different types of exercise, now we're going to talk about what you expect from those changes. So an athlete heart, you see structural and electrophysiologic changes, which we kind of talked about based on the ECGs that we see already. And depending on the sporting discipline, somebody's gender, ethnicity, there's certain changes you might expect to see and others that you might be worried about. Now, more so in endurance athletes, we see these very robust, pronounced changes. And those are the ones, you know, you see an echo and you're like, oh, wow, that's pretty impressive. But the things to remember, which I'm going to get into a bit more detail, are when you see changes, they should be somewhat symmetrical for dilation. So you're not going to see RV dilation by itself. You should see symmetrical dilation. All the chambers should be mildly dilated. In somebody who has an endurance athlete, like a Tour de France athlete, you can see ventricles as wide as 60 millimeters. So it's something that should be symmetrical due to all that volume. Now, also, they should have normal diastolic function. So if you're looking at an echo and you see, their tissue Dopplers are super low, their diastolic function's all out of whack, and you're not sure, is this just athletic heart or is this something pathologic? That can hint you that more so pathologic. Generally, wall thickness less than 13 millimeters. Now, that comes with the caveat, there's a bit of a gray zone from 13 to 15, 16 or so in terms of what's pathologic, what's not, but less than 13, almost always not pathologic. And then something that it's hard to do because no athlete wants to do this, but all these changes should respond to detraining. So if you tell an athlete, sorry, I'm not sure what's going on, you're not allowed to exercise for 6 months, and then we're gonna repeat the studies and see what happens. These changes should start to go back to what's normal for a patient of that age and gender that's not in high athletic competition. And if they don't, that's concerning for a pathologic finding. So getting more into that, so in terms of what we expect, so static exercises, so these are things like weightlifting, powerlifting, that kind of stuff. It's really forceful activities. And what happens is you increase the pressure load by, there's increased afterload, and to maintain cardiac output, you have to increase contractility. And in doing so, you get increased wall thickness with unchanged left ventricular chamber size. So you'll see a lot of power lifters, they come in super thick hearts, small cavities, and this is really to increase cardiac output and overcome that high LV afterload. So when somebody's doing a heavy lift, systolic blood pressure goes up as high as 220, 240, and they have to overcome that. Now, dynamic exercises, those are more endurance things, that kind of stuff. So I usually use cycling or Tour de France. That's a good one. So they have to increase cardiac output, and their PVR stays about the same. So subsequently, they have an increase in volume, and due to this significant increase in volume, they get dilation in all their cavities, not just one cavity, all their cavities dilate. And again, you see balanced cardiac enlargement, and that's something we'll emphasize moving forward. Now, for people who are visual like myself, this is just a visual component of what I just said. So both charts on the bottom, you see dynamic, and on the y-axis, you see static. And on the left side, you see the changes that you expect. So if a very dynamic exercise, you see eccentric remodeling with dilation. And if you have a very static component, you see concentric LVH and don't really get chamber dilation. And then on the right side, I just highlighted a couple common sports and what you see here. So football, basketball, softball, soccer, and then obviously low dynamic, low static, yoga, golf, curling, that kind of stuff. So this is more so for the fellows. I was just gonna touch on it very briefly. I just put together a quick little chart on athlete's heart versus pathologic versus what's in the gray zone. Things, again, to remember. Function should be relatively normal. You can have slightly reduced function, EF of 45%, something like that. Diastolic function should be normal. In young, healthy individuals, which I'm sure you guys have seen in the echo lab, E to A greater than 2, almost definitely normal, especially in young, healthy individuals. An 85-year-old, that's a different story. But just for reference for later so you guys can review, but those are the important things. So now what about somebody who's older, somebody older than 35? They come to your office, they still want to exercise, and you have to tell them what's appropriate and what's not. So we all know, we kind of touched on sudden cardiac death in athletes. Well, what about sudden cardiac death in people older than 35? So we know that obviously coronary disease is prominent in this population and is very apparent, and it's actually the leading cause of sudden cardiac death in individuals over 35. So now we're getting away from the cardiomyopathies, the channelopathies, that kind of stuff, and going to coronary disease. So when we talk about that, again, athletes greater than 35, more than 80% of sudden cardiac death is due to coronary disease. And of course, vigorous exercise can induce a nidus for malignant arrhythmia and cause that sudden cardiac death. So you have to know what's appropriate for those individuals. But of course, we know exercise is always a recommendation, whether you have coronary disease or not. So it's always a recommendation in terms of what you should be able to do. So that's where you come into this tricky situation and have some, nuance into how you should approach this. So let's say you have some strapping gentleman like this guy who you've never met before come into your office and he says, hey doc, am I safe to exercise? I never exercised before. Somebody tells me I need to get in shape and I don't know how to go about doing it. So this is the European Society of Cardiology. This is their proposed algorithm, and we'll get this unknown individual out of here just so he doesn't distract us. So they use essentially what's called the SCORE calculation, which is really their version of ASCVD. It's a bit more in-depth in terms of the variables it takes into account. But as you can see, low risk, less than 5%, high risk, greater than 5%. And based on that, you can kind of go about how you should work up an individual and telling them they're safe for exercise. Really, somebody who's higher risk, who wants to do high or very high intensity exercise, should probably get some more workup. And an exercise stress test is always appropriate as long as they can exercise in these situations. And hopefully they can, because that's what they're asking you about. So what about coronary disease in young individuals? Now that we have all this imaging data that's coming out with CT, we're starting to see more incidents of coronary disease in younger individuals, and whether or not it's pathologic in the athletic population is still up for debate. I was actually asked this on an interview, not here, and I had a crummy answer, so I figured I'd share with you guys. So we know that obviously higher levels of physical activity lower your cardiovascular risk. Now, what about volumes of physical activity? Can that accelerate coronary atherosclerosis, and particularly in the younger individuals? And what about lifelong volumes of exercise? Does that have anything to do with it? So, of course, we know that the density of a plaque, the denser the plaque, the lower risk it is. It's those mixed plaques that are higher risk and more likely to rupture. And based on that, there was a study published, not a great study, but one of the better ones I could find. So it was an observational study, all men, so again, not a great study, ages 48 to 62 who engaged in competitive athletics throughout the duration of their life. And essentially what they did is they looked at metabolic equivalents per minute, per week, and then put them into different categories, as you can see. And then they got CTs with and without contrast to look for coronary calcification, plaque demographics, and what makes up their coronary anatomy. And it's pretty interesting what they found. So I'll just point you to the right side of the screen with the chart there. So you can see the individuals in the highest exercise category had a coronary calcium score greater than 100. And essentially what that's telling you is people who exercise a vigorous amount for durations, years and years, do develop coronary plaque. But what they found is this plaque is mostly stable plaque. So the plaque that they have is dense, calcified plaque. It's not mixed plaque, and it's mostly stable plaque. Now the mechanism of this is still somewhat unknown. And of course, we need some more studies to further divulge into this and figure out why that is the case. Now, there's some proposed mechanisms which are a bit beyond the scope of this, but pretty interesting. So they're, younger individuals, healthy individuals, we're starting to see, calcification in their coronaries, which is something that, you may not necessarily expect. Sorry about that. All right. So now getting into culprits of sudden cardiac death, now that we know all the components of exercise and what's important, what's not important, what do you guys think the second most common cardiovascular cause of sudden cardiac death is? Let's say young athletes, so people less than 35. B, beautiful. So coronary anomalies, we all know HCM is number one, coronary anomalies number two, and we'll get into the rest of them. So more data from the Minneapolis Heart Institute. So HCM, leading cause of sudden cardiac death. And as you make your way around the pie chart, you see coronary anomalies. Now, the thing that's very debatable is myocarditis, which I'll talk a bit more at the end of the talk. And that's because a lot of times we don't know somebody had myocarditis, and a lot of times there's inaccurate reporting. There's not a particular cardiac pathologist doing the autopsy, looking for particular scar inflammation, signs of myocarditis. So something that may be underreported. So just getting into the basics of HCM, I tried to keep it simple because causes of sudden cardiac death is a whole lecture in and of itself. It's the single most non-traumatic cause of sudden cardiac death. We know that. About 1% per year. Ton of genetics, more and more genetics coming out almost on a daily basis. And genes are often being reclassified too, which you should know. So something that was thought to be more pathogenic can be downclassified to something that's less pathogenic. And that's coming out as we move forward with the evolution of this. Family history, obviously important. You're always asking family history for this. And we know this from med school way back when, fibrosis is the key. So you get the expanded extracellular matrix composed of interstitial fibrosis, essentially. Now, just for the fellows, you guys know this, but there's all different kinds of HCM. There's even more on here that aren't listed. So even if you see somebody with something that's not the typical sigmoid HCM septum, it's possible that they have HCM and it's just not the typical phenotype that you're used to seeing. So very common, 1 in 500 young adults. And what about screening relatives? So I'm not going to get into ages and how often, but every first degree relative, ECG echo. That was on my cardiology boards. Every first degree relative needs an ECG and an echo. Genetic counseling, obviously, that's always the answer for somebody with a genetic mutation. And what about exercise? So that's what this talk is about, right? What about exercise? Well, they can do low intensity exercise for sure, but moderate or high intensity exercise, that's up for debate. Now, the caveat to that is, unfortunately, HCM patients die from things other than HCM for the most part. And the thought is that most of these individuals are afraid to exercise, unfortunately, and they're minimally active and they develop things like diabetes, coronary artery disease, and those are the things they pass from rather than manifestations of their cardiomyopathy, which is pretty interesting and unfortunate because there's this thought that it's exceedingly unsafe to exercise. So how can we help these people? So what we do, obviously, talk about their symptoms. Have they had any concerning or malignant symptoms? The European Society actually has a risk stratification score, which I'll talk about on the next slide. And if it's greater than 4%, they're considered high risk. And then their hemodynamics. So do they have an LVOT gradient? Do they have low blood pressure with exercise? Do they have exercise-induced arrhythmias? These are all things that you can find out just with a simple exercise stress test to see if they're low or high risk. Now, low to moderate intensity definitely can consider based on risk factors. High intensity, you recommend against for anyone who has any markers of increased risk. Now, if somebody doesn't have markers of increased risk, that's where you get into a tricky situation. And there's a lot of debate on what to do. There's actually a lot of studies going on right now to try and figure out what types of exercise are appropriate for HCM. This is the score that I just wanted to put up here. So there's an app for it. You can get it on the interwebs, HCM risk SCD calculator. Pretty simple, pretty easy, and just classifies these individuals. And then briefly, I just wanted to put this slide up here because the HCM guidelines changed a little bit in terms of ICD indications. So sudden death, we know, for any relative age less than 50. LVH, we know. Syncope, arrhythmogenic. They added the LV apical aneurysm, which was a minor risk factor in the past, systolic dysfunction. And then they essentially heightened people's awareness on CMR fibrosis with 15% LGE. And the NSVT, they broadened that. It used to just be one run, greater than 3 beats, and fast, which was a bit silly. So they changed that. Now you have to have 3, longer than 10 beats, and fast. So you have to have a couple episodes, essentially, on monitoring. So I picked this gentleman. So Jared Butler, I don't know if anyone knows who this is. So he played for Baylor when they won the national championship and is now on the Utah Jazz. He actually has HCM and saw Dr. Ackerman at Mayo, who everybody knows, who cleared him to play. He's been seeing him every 6 months and further working him up to make sure that he's safe moving forward, which is pretty impressive. So he's playing high intensity, professional sports with HCM. So far, hopefully he does okay. Now, next one, obviously coronary anomalies. We all know coronary anomalies, where they can come from, how they can course. The thing to take from this is the vast majority of sudden deaths for coronary anomalies occur during exercise or shortly thereafter. And there are reported sedentary state sudden deaths, but mostly during exercise. Now, just a couple recommendations. So individuals with anomalous origin of the coronary artery with an acute angle takeoff, so you see the ones with those sharp 90-degree bends on calf, or coursing between the great vessels. Obviously, they're not allowed to play sports, no low intensity activities, nothing, honestly, and they need surgical correction. They're at high risk for sudden cardiac death. Now, the asymptomatic ones with other anomalies, that's when you get into risk stratification, exercise stress testing, and what to do with them moving forward. This was a quick case I had in fellowship last year. Young gentleman kept actually waking up from sleep with chest pain, palpitations, and then was having it during exercise too. We actually stressed him, exercise stress test, and it was normal hemodynamic response, no ECG changes, but he had symptoms. And due to that, we ended up getting some further imaging, and you can see here anomalous left from right and coursing through the great pulmonary, the great arteries. He had surgery, did okay, and is playing sports now, so good for him. And kind of a similar thing, so everyone knows Shaq, but Shaq's son actually had an anomalous coronary and had surgery, and now he's playing college basketball for LSU. So, you know, this is something that, even though it's high risk, if corrected in an appropriate, timely manner, you can avoid sudden death and also continue playing high-level athletics, which is great. Now, let's change gears just a bit into our friend over here, Mr. COVID, which has been with us for way too long now. And the reason we worry about COVID, now getting into it, is obviously myocarditis. So the third leading cause of sudden cardiac death in America for young athletes. And again, that's debatable. There's a lot of autopsy series that actually say it's higher. But typical presentation here, right? Somebody comes in, chest pain, shortness of breath, you see diffuse ECG changes, you're worried about acute coronary syndrome, you get a cath, normal cath, you get a cardiac MRI, you have findings of edema, hyperemia, necrosis, scar, and you know, just like any other virus, that could be concerning in the right clinical setting. But initially, we didn't know that. So initially, you know, the pathology behind it was debatable, and we weren't sure if it was the same as other viruses or what was going on. So we know during systemic inflammation, you get elevation of your inflammatory markers, you get elevation of troponin, NT-proBNP, but where does that leave us in terms of risk of cardiac events, more, less, and what about all those individuals with subclinical myocarditis? Where do they end up in this spectrum of activity here? So during the acute phase, we know somebody with myocarditis, high risk for sudden cardiac death, and because during exercise, you get accelerated viral replication, increased inflammation, cellular necrosis, scar, malignant arrhythmia, sudden cardiac death. So that's why somebody with acute myocarditis should not exercise at all. At least that's the current recommendations. Now, post-infection, this is the gray zone that we don't know. Maybe there's some mild persistent inflammation or scar resulting in this pro-arrhythmic substrate, and 3 months down the line, they exercise, have an arrhythmic event, and have a sudden death. That's something that was worrisome and concerning. So now let's get into some of the data. So I don't know if anybody remembers, but this study was hot off the presses back in April 2020, and I remember it scared a lot of people, myself included. I think it was out of Germany, if I believe, somewhere in Eastern Europe. So 100 patients recovered from COVID-19, of which 33 were hospitalized. They got CMRs and a gambit of other testing, as you can see below, 71 days or so after diagnosis. And they got troponins, 76 out of 100 had high sensitivity, positivity troponin around the 71 days after. And the CMR revealed cardiac involvement in 78 out of 100 with ongoing inflammation in 60 out of 100. And I remember everybody was super scared. Is this actually real? Is this something we have to be very concerned about? And where do we go from here? Now, shortly thereafter, there was an article in the Journal of Cardiac MR that essentially said, pump the brakes, calm down, we need more data. So what it showed us is, and we kind of already knew this, but the data on CMR in athletes is evolving very quickly. So we know highly trained endurance athletes have a 10-fold increase in the prevalence of focal LGE. So was that focal LGE seen in this study due to myocarditis, or was it due to just people who exercise, or where do we go from there? Now, athletes with focal LGE also demonstrate globally higher extracellular volume, which in the right scenario could be a marker of edema, but sometimes is normal athlete heart. And the matrix of remodeling and potential presence of myocardial fibrosis, maybe a feature of athlete's heart as opposed to pathology. So this was just one of many examples in imaging journals that said, not so sure about this study, let's reassess and get some more data. And just of note, they actually found out later there was a lot of fallacies in that study, and whether or not they even used the Ruiz criteria for diagnosis of myocarditis based on CMR was debatable. So fast forward a little bit, March 2021. So actually, my former program director and mentor actually published this article, which is pretty cool. So he studied return to play in individuals with COVID and all the major athletic associations. So what he did was looked at May to October of 2020, professional athletes who tested positive for COVID. It was about 800 or so. And what they found was a prevalence of cardiac involvement was very low. They did troponin, ECG, echo, and then potentially CMR as well. And what they found here is about 0.6%. So again, less than 1% had CMR evidence suggestive of inflammatory heart disease, whether it be myo or pericarditis, that resulted in restriction from play. And the good thing is, and this is in prolonged monitoring too, up to this date and time, there were no adverse cardiac events for these individuals, which is what we're trying to prevent, right? Adverse cardiac event in these individuals. The MLS is actually doing more data that I was looking forward to see if it came out. It hasn't come out yet, but they're planning to publish more data based on the MLS individuals, which should be interesting as well. So then going forward a couple months here, so we have May 2021, the Big Ten had this huge registry of COVID positive patients and, COVID positive athletes in the Big Ten and what they did with them and how they went about it. So diagnosed with COVID, got a CMR, and you can see here the individuals who completed CMR evaluation. Again, this was not based on symptoms, just completed CMR evaluation. 2.3% were diagnosed with myocarditis. So again, very low percentage, and this was not symptom driven. This was just COVID positive, get the test. And if it were based on symptoms, only 5 would have been detected, and that prevalence is 0.3%. So that's pretty impressive and tells us that when done in the right clinical scenario, the yield of CMR in myocarditis, if it's just done inappropriately, just as a gambit of testing, is probably not the right way to go. So more so, in July of 2021, there was another study in college, so 42 universities and colleges, about 3,000 COVID positive patients, and they found the same thing, low prevalence, 0.5 to 3% in this patient population, which is pretty low. And great that there was no adverse cardiac events related to COVID. And that's something that I try to emphasize to a lot of the patients I see who are diagnosed with COVID and are very worried about returning to activity. All these big studies have shown thus far no adverse cardiac events, which is great. Now, in this study, this 3% here was based on CMR data obtained in individuals that were not based on symptoms. So it's just COVID positive CMR, found 3%. The 5%, 0.5% is based on individuals who had symptoms that were persistent and concerning, got baseline workup with ECG, troponin, echo, and had a reason for a CMR. So when you do it in that regard, definitely lower prevalence and probably more appropriate to go about it in that route. So just quickly, my experience. So we had a nice sports cardiology clinic at Lehigh, and I was lucky that we got to see over 150 COVID positive athletes. And we did this evaluation kind of based on the last slide, tried not to order too many CMRs. We ended up ordering 3, and none of them were positive, which is great. And all these individuals returned to sport, they're doing well. And it's something that shows me, well, we see it in these huge studies, but what about real world data and personal experience? I'm having the same results as individuals who do these big studies, which is always reassuring. So what do we know about this? Well, are all those who get COVID equal? No. The answer is no. So if you're generally asymptomatic, don't have persistence of symptoms, don't have cardiovascular symptoms, you're at exceedingly low risk for the development of myocarditis. The ones who are more symptomatic with more severe symptoms, that's when the risk goes up. What about imaging? Well, again, we know that really what we should be doing is getting CMR when appropriate based on risk stratification. It shouldn't be used as a screening modality because we're going to see patients that are positive just based on imaging without actual clinical myocarditis. So it's important to use it in the right setting, ECG, troponin, echo, potentially CMR if worrisome findings and persistent symptoms. And what I generally tell patients, at most 3% prevalence. So more so towards the 0.5, but at most 3% prevalence if you look at the data. And in these patients that were seen in these studies, there's no adverse cardiac events, which is always important because people always ask about that. So everybody comes in very afraid. So this is, I'm not going to go too into detail of this, but this is the proposed algorithm that was published in JAMA in terms of how to reassess COVID-positive patients returning to exercise. And essentially, moderate or severe symptoms, they need further testing and should be evaluated by a physician, whether it's initially a primary care doctor and then a cardiologist or a cardiologist right off the bat. And if you look at the algorithm, CMR is all the way at the bottom, so you're not getting that kind of stuff right away. So, what about the vaccine? Now everybody's afraid of the vaccine. Does it cause myocarditis? So what does the data show? So individuals receiving the COVID vaccination, what they looked at in this Providence healthcare system, which is out west, they found 20 individuals out of the over 2 million that got the vaccine had vaccine-related myocarditis, so 1 in 100,000, and 37 pericarditis, so 1.8 per 100,000. Now, the myocarditis data showed about 3 days or so after the vaccination, mostly after the second dose. Majority were male, which we know. 19 were admitted to the hospital, but no readmissions, no deaths. So again, very safe, no adverse cardiac events. Nobody had, I didn't put this in here, but nobody had persistently low left ventricular ejection fraction, which is good, and definitely reassuring. And the reason I mention this is because, of course, athletes are getting vaccinated. I have seen athletes with COVID myocarditis, and I have seen athletes with vaccine-induced myocarditis. And it's important to know, well, what should we say when they get myocarditis? So the ACC and ESC guidelines, they don't differ too much. No participation immediately upon diagnosis, and then 3 to 6 months or so thereafter, they can be reassessed. And initially they should get troponins, biomarkers, echo, Holter, 48-hour Holter. And then if all those look good, 3 months, reassess, repeat the study, and if everything's negative, they can get an exercise stress test. If the exercise stress test looks okay, they can go back to sport. And the reason is the pathophys we talked about earlier, the worrisome for a nidus for ventricular arrhythmia. Now, the role of biomarkers, it's in the European guidelines, it's a bit debated. And the role of repeating a CMR, if it's positive initially, also debated. The European Society says yes, the ACC says maybe. So something that I think I usually just take on a case-by-case basis. So now going to sudden cardiac death. Now, we all know this answer. I'm just going to move forward with that. But obviously, acting quick is important. And I'm just going to give a couple examples and what societies have done. So the NCAA and all professional sports now have an emergency action plan. So you see even in gyms locally and in high school, there's AEDs everywhere. And there's also a plan on how to use the AED, what to do, how to save somebody, and where to go from there. We're working on this, trying to get more standardization, moving forward to try and save individuals' lives, obviously, but something that's made big strides. And we see that. I have 2 examples here. So I believe this was 2 years ago or so. I don't know if anybody remembers, but an NHL player had an arrest on the bench and was very, very quickly started having compressions and was defibrillated. And he ultimately ended up living. He got an ICD, he's doing well. And it's really because people are aware as opposed to what happened to Hank Gathers back in the late 80s. People had no idea what was going on, and unfortunately, he passed away. Now, more recently, we have Christian Eriksen, who one of the best soccer players in the world, in my opinion, before this happened. And unfortunately, during the Euros, it says Euro 2020, but that was actually played in 2021, had a arrest on the field. I still haven't seen, probably because of HIPAA, I guess, what his diagnosis was, but he's not playing soccer, obviously, but he was successfully resuscitated. His teammates actually performed CPR, which is pretty horrific. And then they got an AED on the field, defibrillated him, and I mean, he's alive, so it's great. So what did we learn from all this, and what are my big take-home points? So sports cardiology, new and evolving field, data's coming out all the time. I'm trying to stay up to date as much as I can, but there's always something new. The big things from my perspective is asking syncope, chest pain, worsening shortness of breath. Progression's big. So you might say, somebody says they're, again, able to do 3 miles just fine, but then if you probe a little more, a month ago they were doing 5-6 miles and their exercise regimen hasn't changed. That's a bit concerning. We all know the 3 leading causes, so hypertrophic cardiomyopathy, anomalous coronaries, and myocarditis. Myocarditis, very debatable. Lots of autopsy series that say it can be as high as 25% or so, but that's not yet made its way into mainstream literature. And everybody asks, prevalence of COVID myopericarditis, it's very low, 0.5 to 3%. Athletes that get it should undergo the same testing protocol generally that patients with other viral myocarditis get, and should be refrained from playing sports for 3 to 6 months. And when you get the testing, again, symptoms matter. So moderate symptoms, severe symptoms, hospitalization, any cardiopulmonary symptoms, that's when you should really say, maybe we need to take a pause and step back, get some baseline testing before we say, go ahead and play your collegiate sport. And I think that's all I have, and because it's frigid out, I decided to put a picture right before this lecture of where I was before I started at Cooper. And thankfully I came back and they didn't have to find a replacement for me. So if anyone has any questions, I'm happy to answer.
Yeah, that was fantastic. So Mario, that was really above and beyond. It was a terrific review of a broad array of topics. I have one quick question, and then I hope the others will jump in.
Yeah.
I was very intrigued by the, really by everything you said, but particularly the coronary calcification in elite athletes, or the more you exercise. What's the explanation for that, and why is that not a bad thing?
Yeah, so the main proposed physiology is just due to, how do I describe this? They did kind of like when you look at a bicuspid valve and you do those images that show where flow is hitting the proximal portion of the ascending aorta, and that's why they're more likely to dilate. The thought is that it's due to higher intensity flow over a more rigorous period of time that leads itself to this somewhat dense calcific plaque that's more protective in nature as opposed to pathologic and dangerous in nature. But the verdict's still out, and there's a lot of proposed mechanisms, but that's the one that a lot of the experts mention as being theoretical, I guess. But the answer is the verdict's still out and yet to be known for sure.
Sure. I asked that question in part. I have 3 patients that have very, very high cholesterol levels, more than 300, and they don't exercise at all. They're just totally sedentary. They're in their 60s. We did coronary calcium scores, and their scores are all 0 with cholesterols of 350. So obviously, we don't understand this disease particularly well. But anyway, thanks for sharing that. Anybody else have questions?
Yeah, Mario, I have a question, different topic, and maybe not quite germane to your topic, but I've seen maybe a half a dozen people now with long haul COVID. And these were people young people in their 30s who were active. They're not athletes necessarily, but they were regular joggers or regular walkers. And their symptom is that they can't do what they used to do. They could jog for 3 miles before, and now they can't walk for half an hour. And the basic cardiac exam is normal, so I've been ordering CMRs on these people, and so far I haven't seen anything. But
Yeah.
do you have any insight as to what's going on?
So they actually talked about this there was a sports cardiology meeting this summer about all these long haul COVID people who unfortunately can't exercise like they used to. And obviously there's no consensus yet, but a lot of the experts were saying you can risk stratify doing exercise stress or even doing a CPET. If nothing comes back worrisome or concerning, the data now is showing that actually exercise is beneficial. So even if they can't do it the way they used to, recommend that they try and do it and gradually increase exercise over the course of time. I've ordered CPET in a couple and found essentially results that weren't worrisome or concerning. So I prescribed exercise, and I've seen one back in the office, and she's doing much better. I don't know if the exercise was cause and effect or not, or if it was time, but that's what a lot of the people in the meeting were saying, to kind of make sure they're not high risk and then go forward with telling them they can exercise and trying to push themselves a little bit.
But the etiology, is it skeletal muscle? Is it pulmonary? Is it cardiac? Or we really have no idea?
I think probably the last thing said. However, I do know the initial variants, a lot of it was pulmonary in nature. But I think that's still something I was actually trying to figure. I figured somebody was going to ask that, so I was trying to read about it before this, but I didn't find too much new about it.
Other questions?
Yeah, I've seen few patients who usually are athletic, not like professional athletic, but they want to up their games.
Yeah.
Specifically, I've had a couple of patients who, let's say, run 3 to 6 miles normally, and they came to me. They want to start running or training for a marathon.
Yeah.
Are there any recommendation for those kind of patients?
I think in the setting of a low-risk patient, gradual and moderated exercise is what the European Society recommends. Don't go from 0 to 100 right away. In the higher risk patients, usually exercise stress test before you prescribe a higher intensity exercise. So generally somebody who's athletic, healthy, and they're not high risk, I always tell them, start slow and gradually increase over time. Don't go from 0 to 100 right away. That's what the European Society says. The ACC doesn't really say much about it. And then high risk patients, exercise stress tests usually before saying go ahead.
Mary, it's a question about a similar question to what was just asked from Simon. I do see patients that are in the same situation, haven't been ill, had a thorough workup, and they're otherwise negative, and they want to step up their game. And I know in the past, in my previous life, we in the exercise physiology arena, they did cardiopulmonary testing. They had a nutritionist to make sure that they were adequately nourished to do the activities that they wanted to do. Is that something that you see in the program that you're developing?
Sorry. Sorry. What's the question again?
Okay, so I was asking, similar to Simon's, where we see patients that are avid, that avidly exercise and want to step up their game. And in my previous life, we had a very strong exercise physiology laboratory.
Yeah.
And what they would do as part of their evaluation, their cardiac evaluation, they would also get cardiopulmonary testing, and they would actually see a nutritionist to determine if the requirements that they had were feasible for what they really wanted to do. So I was wondering if that's something that you see as a possibility that you would incorporate into existing evaluations of the patients that you're hoping to see in the future. Not people who are sick, people who are otherwise healthy.
Right. Sorry about that. Thanks. Yeah. So I've seen a bunch of patients like this, and I actually I've been having them see nutritionists, and the ones who want to do more high intensity, I've been doing cardiopulmonary exercise testing to see where their baseline is and risk stratify if they had any symptoms. And I think it's definitely very important, in not that it's applicable via insurance, but when I did the same thing in college too with exercise phys, and I worked with a lot of the athletes there, and we would do nutritionist evals and VO2 max testing on all of them in order to establish a baseline and then grade their exercise response appropriately and try to manage their quantity of exercise while also getting enough intake from a nutritional standpoint in terms of responding appropriately to whatever they're doing. So I definitely think it's appropriate and hopefully incorporated more so into care.
Mario, can you hear me?
Kind of, yeah.
Mario, can you hear me?
Yes,
Yeah.
yes, we can hear you, yeah.
Okay, that was a great talk, and
I think we lost you.
We lost the Dr. Cha. I mean, golf is not considered a sport, so you can't answer the question.
very sense of my piece. So my question is actually the Cooper tried to launch the athletic program, training program for a few years ago, but with obvious reason they were not able to. We decided not to start. But anyway, so my question is, when you screen NCAA as well as professional sports, what kind of screening they do for the athletes?
So the NCAA, very surprisingly to this point, still doesn't have very standardized screening. Division I athletes generally get physical exam, EKG. Now, professional athletes, I know they, for the most part, when they go to the combine, at least speaking for the MLS and NFL, they all get physical exam, ECG, and the majority of them get echoes as well, which may be a bit overkill. But you know, there have been a lot of scenarios where they caught pathology. But for the professional sports, majority get exam, ECG, and echo, and that's usually at the combine prior to entering the whatever sport it may be.
Or how you want to screen the, at Cooper if we send a patient to you? So what is your protocol gonna be?
I'm trying to do it symptom-based, which is what my mentors taught me. And you know, we essentially get an ECG on everyone, and I'm okay with that. And basically, I like to evaluate past symptoms, current symptoms, and then family history is the big thing. And I try not to over-order tests. You know, it's hard because you don't want to miss anything, and I'm still, you know, adapting to that. But the way my mentors did it was very symptom-driven, which is what the professional societies recommend as well. So that's what I've been doing.
Thank you.
Yeah, I'm glad you brought up this slide again, because I just have a question. If a young, otherwise healthy, but like professional and very serious athlete was coming to you, would you consider prescribing something that would prevent concentric remodeling, like an ACE or something? Especially if they're in one of the top left corners, like the powerlifting, or I don't know, one of those other kind of sports.
I haven't. I don't know. I know there's, unless somebody could correct me, I don't know if there's any data to show that it's beneficial. I try to base everything I do off of data to guide my approach. I've thought about things like that, but I have not done that, and I don't know of any at this point in time. At least my mentors never did it, and I don't know of anybody doing it just yet. But definitely a good thought, for sure.
Thank you.
In general, the remodeling with sports, as you said, is physiologic. It's driven by their activities. So suppressing that may actually hinder their athletic performance. So you have to think about all those things. But that was a very interesting question. I think we're just about out of time. We're a little bit over, actually, but I think we all agree this was an outstanding ground rounds. We're really grateful to you, Mario, for bringing some new information to all of us. I want to thank you very much. I want to encourage everybody to fill out the evaluation forms, get them back to Tina Moorfeld. If they're in the conference room, they may be there physically to fill out, or else the rest of us online, they were sent to us electronically. And we thank you very much.
Thanks.
Now,